Hello, everyone. Welcome back from lunch. Kathy Mann. Welcome back from lunch. Oh, that was like very loud.
Just percent here.
Okay, guys, thank you for coming back. I hope everyone had a great lunch and they were listening to some great lecturing while they were eating their lunch. So we're going to continue our day with Christina Choi and Nikki Lee, both staff nurses at our cardiac surgery ICU at Mount Sinai Morningside. And today they're going to be going over unit practice councils in a CSICU.
Thank you, Shauna. As Shauna has mentioned, my name is Christine Choi, and this is Nikki Lee, and we're both staff nurses at Mount Sinai Morningside. And we co-founded our first unit practice council about 4 years ago, and we're very excited to share our experiences with you. So the four main objectives for today's presentation will be, number one, the purpose and the importance of the unit practice council. Number two, our own UPC structure at Mount Sinai Morningside CSICU. Number three, some of our project examples. And number four, our recommendations for a successful UPC. So first, we want to know what a unit practice council is. So what is a UPC? In short, it is a collaborative body within a healthcare setting, typically aimed at the unit level. It is a platform for nurses to come together to discuss and share various aspects of nursing practice. In this council, the nurses take the lead in implementing, monitoring, and evaluating the standards and practices along with the wider multidisciplinary team. The primary focus is on activities such as policy development, evidence-based practice, education, quality improvement. That was a test to see if everyone was paying attention. Are we okay now? Okay, back to the beginning now. So we're okay now? Okay, so the primary focus is on activities such as policy development, evidence-based practice, education, quality improvement initiatives, and fostering communication among various disciplines. Ultimately, the primary goal is to enhance, improve patient care outcomes and our work environment. UPC is important because it promotes shared governance. And shared governance is the collaboration and the distribution of authority among various stakeholders, especially those that are directly involved in patient care. Research has shown that it is the ideal level of professional governance for achieving excellent nursing outcomes. And achieving this ideal level of governance has its benefits, such as promoting nursing empowerment, accountability, and engagement, improving clinical practice and patient outcomes, and creating a healthy work environment, and also promoting the synergistic interdisciplinary collaboration. In summary, UPC is an expression of shared governance. So why do nurses want to create a UPC, and why did we create one on our unit? So to answer this question, I want to share with you my side of how our UPC came into fruition. So when I interviewed for my current position at Mount Sinai Morningside about 6 years ago, I was asked what I expected from this job, and my answer, which I still remember till this day, was that I wanted to work within an organization that I could grow with. And I guess my manager liked that answer because I was hired and I'm still here. So after going through the orientation process and learning the ins and outs of the unit, I began to see some areas that needed changes, so that could impact our daily workflow. After sharing my thoughts to some of my colleagues, I found out that I wasn't the only one that had these ideas. But at the time, I don't think we knew how to take those ideas into like a tangible change. So after throwing ideas back and forth, Nikki and I went to our then manager and asked if we could create our own UPC to work on these projects. The projects, which will be discussed in a little bit, improved our patient outcomes and satisfaction. It created an efficient environment for us, And because the initial stakeholders were us, the bedside nurses, it created a sense of accountability and empowerment, which in turn, it improved our job satisfaction. And it turned out to be a great resume builder too, because who knew 4 years ago that I would be speaking to all of you here. Okay, to go into how we created this UPC, this is just a general overview of our unit. We are a 26-bed cardiac surgery, cardiac care, intensive care unit in a tertiary academic center. On average, we have about 10 RNs and 2 NAs and 2 unit secretaries per shift. And in order to have fair representation, we came up with the following positions and responsibilities. We have 2 co-chairs representing each shift. They're responsible for keeping the focus of the committee and conducting the monthly meetings and keeping each member accountable. And we have a secretary who acts as a communicator between the committee and the unit. They're responsible for keeping and disseminating meeting minutes. We have a treasurer and researcher, which is a combined role. They're responsible for seeking funding for our projects when needed, and as well as being the resource in exploring evidence-based practices to support our projects. The 2 board members, 2 from each shift, act as liaisons between the UPC and the rest of the unit. They are the ones that maintain the everyday network of communication and in a way lead the way into transform our ideas into actions. And we also have representatives from the unit secretaries and the nursing assistants. They are vital members of our unit and their inputs are crucial to our projects. This is our purpose statement. It reads, our purpose as a unit practice council is to implement our institution's value system as we navigate through the process of improvement and innovation. Purpose statement is important as it clarifies our focus and communicates our goal. It helps in keeping the motivation and maintaining this unified team. We also created some bylaws for standardization, and this is extremely important for accountability and sustainability. We realized early on that in order for this UPC to continue, we needed to have some set of rules and guidelines for our current and future members. Components of the bylaws include the defined roles and responsibilities that I just explained, the process of selecting, and as equally as important, the process of deselecting members when necessary. Member accountability, this includes attendance, engagement, and ownership of projects. Also, the maintenance of transparency within the unit, and some ground rules for our meetings, which include like setting a recurring date and time for our monthly meetings. And this is our roadmap for our project work process. When there is a new UPC project idea, this is discussed with our manager and leadership by the co-chairs to see if the project is in line with our unit's focus and if it's feasible. Then this gets taken back for development. Once the project is fully developed, it goes back to management for final approval. And once we get the green light, the projects are implemented through various channels such as in-services, sending out emails, daily huddles by our charge nurses, and the information getting posted on our UPC board. And once the projects are implemented, there is an evaluation process. We do this through staff surveys, and this is an important step because it helps us to find areas for improvement in implementing our future projects. This is to show that that UPC is not a standalone committee, but it is a vehicle for any member within the organization to utilize to implement changes that can produce positive outcomes in patient care. And because this is not a standalone committee, it's essential to get most, if not all, of the stakeholders involved. And we did this in 3 different ways. We invited everyone to our monthly meetings, and this is why it's important to have that set date and time for the monthly meetings. It's just easier for everyone to say, for example, like every first Tuesday of the month, it's the UBC meeting. So then anyone could just join in. Second, we had surveys to see what was important to the vast majority. And third, for those of us that are a little shy or wanted to remain anonymous for whatever reason, we created a virtual suggestion box so that anyone could leave comments and/or suggestions. And this is actually the virtual suggestion box that we created that were posted on our unit with the QR code. And you could see some of the suggestions that were left. And not all suggestions will and can lead into a project, but this is shared with the leadership. This gives us a general idea of what the unit is thinking. And now I'll pass it on to Nikki to describe our projects.
Thank you, Christine. So Christine has described to you how our UPC is set up. I will show you how our UPC takes action. First, we look into, first we look for ideas to improve our unit. We do so by looking into these 5 different areas. First, we look at our unit safety events to see if there's anything that needs to be addressed right away. We look at our press scanning score to see if there's any way we can improve our patient experience. We consider staff's input from virtual suggestion box. We look at our workflow and practice to see if there's anything we can do better on the unit. And also, we look at our hospital-wide policy to see if there's any gap in practice that we can close. Next, I will show you examples of some of our projects that were inspired by these 5 areas. These projects demonstrate how UPC initiates change on the unit. First is our cath lab SBAR, This is our project for a safety event. In the safety event, a femoral arterial sheath was removed by one of the travel nurses. The patient developed retroperitoneal bleed and needed surgical intervention. Upon debriefing, UPC noted that we have more travelers and float nurses on our CCU side who are not familiar with our policy. Also, our cath lab report is not standardized, so it was easy to miss important information. To address this problem, we created a cath lab SBAR. It is an easy-to-follow guideline for the nurses to ask the right question and take certain safety precautions. Now this is part of our report sheet. And since implementing this project, we haven't had a similar safety event since. Next is our post-op teaching project. To improve our patient experience, we look into our press scanning score for ideas. We saw that we score low on the questions for patient education. To address this issue, UPC created a simplified teaching outline for the nurses just to remind them of the education point they can emphasize in the daily care they already provide, such as incentive spirometer use, ambulation, incision care, pain management. Currently, this teaching outline is part of our nursing orientation, and the goal is to incorporate these teaching points into our everyday conversation with our patients. Next, I want to show you 2 examples from our virtual suggestion box. First is the broken equipment pathway. We received multiple input from staff that many of our equipments were not working, hindering our care for our patients. UPC looked into this issue and discovered that it's not because our equipments are breaking down all the time. Instead, the malfunctioning equipment stays circulating around the unit because the staff didn't know how to process them or send them out to repair properly. In response, UPC developed a broken equipment pathway to clarify and standardize the repair process, so staff can follow accordingly and send equipment out for repair in a timely manner. Since implementing the process map, we have seen a quicker turnaround for equipment repairs. Sorry, did I jump too far? Anyway, here's another project for our virtual suggestion box. This one focuses on interdisciplinary collaboration. We got comments from nurses looking for an easier and a more efficient way of communicating with our providers. On our unit, communication between nurses and providers used to be all face-to-face interaction. While this method is appropriate for urgent matters, it is not practical for routine issues or if the provider were to step away. It was frustrating for the nurses to have to leave the bedside to look for providers for simple orders. It is also unsafe for the nurses to not be able to locate the providers if they were to step away. UPC decided that it would be more efficient for the providers to utilize the texting feature of our EMR called AdvPerioCare. The provider usually have the EMR app downloaded on their phone, so then nurses can still text them while they're away. We reached out to the medical team to encourage them to adopt this practice, and they're agreeable. Since changing the practice, the nurses reported improved communication with providers and felt that their workflow was less disruptive. Next, I want to show you a project from our unit-based initiatives. First is our Nursing Assistant Workflow Improvement Project. On our unit, we refer our nursing assistants as NAs. UPC as a whole saw there could be better teamwork between our nurses and nursing assistants. With the help of our NA representative, we tried to see things from their perspective and identify barriers in their workflow. We saw several issues. First, tasks were left from one shift to another shift with no accountability. Second, certain nursing practice created repetitive work for the NAs, such as asking them to send lab physically instead of using a tubing station. So UPC proposed solution to address these problems. First, for the issue of accountability, UPC created a standardized workflow to help NA prioritize their responsibility in each shift. For the issue with nursing practice, UPC as a group convinced our nursing staff to utilize a tubing system for labs consistently. The change that UPC made were well received by the NAs. They felt like now they have more time to perform their tasks. The standardized NA workflow also used as a guideline for our flow NA who are not familiar with our unit. Second, I want to show you another interesting project on our unit. It's called aromatherapy. Some case studies have shown that aromatherapy can possibly improve sleep quality, and research has shown that poor sleep quality leads to higher risk of delirium. Based on this information, UPC proposed of using aromatherapy as an intervention to prevent delirium in our cardiac surgery patient. To proceed with this idea, we performed a literature review and met with stakeholders such as the ID department and our medical directors. While this is a good idea, we realized that more research is needed to support this intervention. So right now, this project is on hold until UPC has more capacity for nursing research. We want to use this idea to show you that not all ideas lead to implementation, but that doesn't mean that the idea is a failure. It's that it's just part of the process of prioritization. Last but not least is our hospital-wide initiative. UPC looked into our hospital policy and saw that there's a gap in our current PIV policy and what is recommended per evidence-based practice. The Infusing Nursing Society states that PIV can be changed as clinically indicated, while our policy is still the traditional way of changing every 4 days. Our nurses have reported that having to replace a functional IV is an obstacle in our workflow. It delays our transfer of patient out of ICU, and most importantly, creating unnecessary pain and discomfort for our patients. To address this gap in practice, we did a literature review, presented to our stakeholders, and we were permitted to do a 3-month trial. The project is still in its planning phase, and we plan to roll out next year. These are the 7 examples of our UPC project is inspired by the 5 areas of ideas. In each project, UPC worked as a group to identify the root cause of a problem, develop interventions, and go through the UPC roadmap to implement the change on the unit with the goal of creating a positive outcome on the unit.
Okay, so looking at all this, what was effective and how do we maintain this effectiveness? In looking back at our projects and seeing what made our UPC successful, we came up with the following 4 main factors. Number 1 is strong leadership support. When we first started our UPC, we had a very strong support from our manager who not only guided us in how to lead a committee, but also connecting us with the right people. And more importantly, our managers stood behind our work and our projects and provided reinforcements when necessary. Number 2, active unit engagement. We achieved this by being transparent through our open communication by publicly posting our meeting minutes and our annual reports. And this allowed us to be seen and valued as a change agent on the unit. And number 3, defined council structure. Having a well-defined set of laws helped us shape our UPC. And last, accountability. Our members brought to the table extremely high levels of accountability, which allowed our UPC to function effectively. A recent study revealed that there is a significant positive correlation between UPC functionality and nursing accountability. So looking at all this, our recommendations for maintaining a successful UPC in the future is to evaluate the integrity of the council based on these 4 factors and provide early intervention when necessary. And this brings us to the end of our presentation. Thank you so much for listening to us, and I hope that we provided you with some tools and ideas to take back to your respective units.
Does anyone have any questions for Christine and Nikki? Go to the microphones, please. Omar, you go to that one.
When you guys first started the UPC, how were you able to increase engagement from the staff to want to participate and further along the projects?
So I think because we knew from the beginning that, Nikki and I went to our manager to create this UPC. So it needed a lot of marketing and selling. But once we had, enough people that were interested, and when they saw the work that we were doing, more people wanted to join and be part of it.
I wanted to ask about the Treasury position. How have you guys sourced funding, and how have you guys utilized that treasurer?
So that was a role and position that came about for looking into the future. So we haven't had any projects as of day 2 that needed funding, but that was just, looking into the future if we were to ever do bigger projects.
We did. There's one instance that we did. A couple instances that we did need funding. For example, one of our members, Mallory, was on our UPC project. She wanted to do a sunshine committee, which is kind of like an event for people to get together to raise morale. She asked around, leadership, staff for donations, and we got funding for a party. So that would be what Treasurer will be doing, to focus on managing the money, making sure details of how it's spent.
Well, I also think right now, all the projects have been funded by the hospital, but in the future, we might want to look at grants. So that's why the treasurer and research titles combined together.
Yes.
But anyone else have any questions? Because I just wanted to make one observation. All of the presentations kind of link with each other about how we improve our care for cardiac surgery patients. I mean, Nikki and Christine talked about SBAR, so did Mallory and Marcy. They talked about Marcode, so did Dr. Yemen. And then engagement of staff and nursing assistant workflow. Mackenzie spoke about that with engagement of pressure injuries. So everything that we do in all the members of the team is really an interdisciplinary approach. And even though all the topics were different in nature, they kind of relied on and were foundational of all the basics of what a team is and what communication is. So I just wanted to bring that up into everyone's awareness.
You developed that
Because guys, this is being taped, and
So you developed that SBAR for the cath lab, and I've noticed the people on 4 West, the step down, they get patients from the cath lab. So is that being shared through the institution, or that one is only being used on 6 East?
So right now, the SBAR is specific for the ICU, 6 East, but we could certainly help in developing one for the step-down unit. Or they could, use the SBAR as a guidance.
I would second that for my unit as well, for 9 East, because I think there's an application for that.
Because I have noticed on 4 West, they have a lot of problems when they're getting patients from EP lab and the cath lab. They haven't notified a team, so when they come to the floor, they can't access the providers because they haven't been signed out. So I would think that would be helpful if that was included on an SBAR.
Yeah, we can share our template with the unit, and you guys can modify to your preference. Yeah.
Okay, any other questions, guys? Okay, thank you guys. Up next, we have Fred Zanau, who is a staff nurse on our cardiac surgery ICU. He's also one of our preceptors and also one of the mentors and main drivers of the cardiac fellowship program. He's going to be going over theory and skills of balloon pump, and then theory and skills over pacemakers, and there's actually some equipment he's going to use, so this is going to be a very interactive session.
Okay, so the first part, we're going to talk about the intra-aortic balloon pump. We'll talk about some theory first, then we're going to bring a balloon pump up here with one of the reps from Marquette. He has a simulator. At that point in time, I would hope that maybe everybody could move in a little bit because the balloon pump is going to be over here. But for right now, everybody's seated in a fine place. So basically, there's two reasons to use an intra-aortic balloon pump. One is for coronary perfusion, and one is for cardiogenic shock, or to decrease the resistance that the heart has to pump against. But to make it more simple, I'm just going to give a little example. If I'm walking and I get chest pain, I sit down and my chest pain goes away. What changed? The demand on my heart changed. I decreased the demand, so my chest pain went away. Now I'm walking and I get chest pain. I sit down, it doesn't go away. And now I take a nitroglycerin. What changed? I increased flow to the coronaries by dilating the coronaries, and my chest pain went away. Now I do both of those things, then chest pain doesn't go away. Now I have to figure out another option. If I'm ischemic, maybe I don't want to use inotropic agents to increase my cardiac output because that increases oxygen demand on the heart. So the next choice could be something mechanical, like an intra-aortic balloon pump. Okay? But again, you may see this balloon pump being used for many different things, maybe prophylactic for a procedure, or maybe a patient having trouble coming off bypass, but it all comes down to a problem with perfusion and forward flow, or cardiogenic shock, a weak heart. The balloon pump itself has different pieces to it. The first piece would be the sheath, or the introducer, or the cordis. The next would be the balloon pump the balloon in and of itself. To choose the right balloon pump, it goes by height. It doesn't go by basal surface area. If the patient is below 5'4", they get a 40 cc balloon. If they're above 5'4", they get a 50 cc balloon. That's in the Marquette. The Arrow, if your institution uses an Arrow, the sizes are a little bit differently. It would be 30 and 40. Okay, so the slide is a little inaccurate there. I wrote that it's 5'4" to 6 foot. That's inaccurate. It's 5'4" or above. There is no balloon after 6 foot. It's a 40 or a 50 cc balloon. Okay. The next thing we have to look at is placement of the balloon pump after it's inserted. You see, there's a radio-opaque line marker right there. Okay. That marker is an indication of the most distal part of the balloon. There is a marker for the proximal part of the balloon, but most of the time we don't get an X-ray to see that marker. If you see a marker that's very low, don't always assume that's the distal marker. It could potentially be the proximal marker. You don't want to use that marker thinking it's the distal marker. When you're getting the X-ray to look for placement, you have to have the balloon on standby during that period of time. You can't have the balloon inflating and deflating. That tip will move slightly on inflation and deflation. It should always be on standby for the X-ray. And the placement of the balloon should be between the second and third intercostal space if the X-ray is taken perfectly straight onto the patient. Because if these are my ribs and this is the balloon behind it, say that this is my third intercostal space and you see the balloon like this, if I take the X-ray at an angle like this, my markings are changed because the balloon is not right up against the rib cage. So a second marker, if you're unsure, you should see if you can find the aortic arch or see that the balloon isn't starting to make that turn. Okay, so that's another. But remember, the X-ray has to be taken with the balloon being deflated and on standby. There are some contraindications to using the balloon, which kind of would make sense. Severe peripheral vascular disease. Aortic valvular insufficiency, because we don't want to have a balloon being inflated against a valve that is shut, increasing pressure against that valve if it's already insufficient. Aortic aneurysm or aortic dissection. Here we have to start thinking about what the heart is actually doing during its cycle. During systole, the heart contracts, the aortic valve is open. The blood fills into the aorta. As the heart begins to relax and the pressure in the aorta overcomes the pressure in the left ventricle, the aortic valve slams shut. That's your dicrotic notch. You'll see it, and the valve shuts like this. Boom. That's why you see a little hump for your dicrotic notch. Okay? That's when coronary perfusion begins. Because during systole and the heart is contracting, the coronaries are also shut because the contraction of the heart is constricting those vessels. Now, during diastole, those vessels relax, and the origin of those vessels is right off of the ascending aorta, and that's where the blood goes into the coronaries. Okay? Then during systole, the aortic valve opens, and the heart has to pump against the resistance that's in the arterial system, which is notable, your SVR. Now, when does the balloon inflate? How does it take care of it? During diastole, or just at or just slightly above that dicrotic notch, the balloon will rapidly inflate, augmenting diastolic pressure to 10 to 15 points higher than your systolic pressure, forcing more blood into the coronaries. That's how the balloon takes care of the perfusion. Now you have a balloon blown up inside of the aorta. I'm about to show you this slide. So that's a coronary. If a coronary is narrowed and we increase the pressure into the coronaries, you will get more blood flow into those coronaries. Now, during diastole, the balloon remains inflated the whole time of diastole. A split second before before systole, you have a balloon now inflated inside of the descending aorta that will now rapidly deflate, creating an empty space or almost a vacuum, so that when the heart does contract, it will contract against much less pressure or afterload, in this case, systemic vascular resistance of the left side of the heart. So it increases perfusion, decreases afterload, and offloads the heart itself. When we're talking about oxygen supply and oxygen demand, oxygen supply is controlled by how much oxygen is being extracted, obviously. Diastolic time. The shorter the diastolic time, the less coronary perfusion we're getting. Diastolic pressure. The lower the diastolic pressure, the less coronary perfusion we're getting. And coronary blood flow. As far as oxygen demand, preload, because the more the preload is, the more the demand on the heart is. If you have more preload because of Starling's law, which you had mentioned before, contractility will be more, hence a higher oxygen demand on the heart. Heart rate, the higher the heart rate, the less diastolic time we have, also the more demand on the heart. And afterload is also the resistance that the heart has to pump against creates a demand. Okay, now this is a typical waveform. And as we're going along the waveform here, I'll explain to you what it's doing. So this here would be our unassisted diastolic, or our end diastolic pressure. We then here have our anachronic limb. This is the start of systole. This here would be our peak unassisted systolic pressure. This here going down is still systole, so the balloon is not inflated yet. Then this is our dicrotic notch. That would be the start of diastole. When the balloon is not working on this beat, this would be our normal afterload that the heart has to pump against, or our peak end diastolic pressure. Again, this here again would be our unassisted systolic beat. This would be our dicrotic notch where the balloon rapidly inflates, increasing diastolic pressure to hopefully 10 to 15 points higher than our systolic pressure. The balloon will remain inflated all the way down to here, and right about here rapidly deflate, decreasing the peak end diastolic pressure, or the assisted diastolic pressure, decreasing the amount of resistance that the next beat has to pump against. Hence, we can see that our assisted systolic pressure is lower because it did not have to create as much pressure to get the same amount or more volume out. And this is just another example of that waveform. If we inflate the balloon too early, now the representative, Ed, he will go over with you that the balloon automatically controls this. But you may see waveforms that look like this if the balloon is not working properly. and you have to be aware of it. So if I see a beat that looks like this, you see here, this would be my unassisted systolic. This is my anachronic limb. Then I'm still during systole here. The balloon should have inflated down here. It's inflating early. So the heart, during this period of time, is still contracting and blood is still leaving the heart. And now I'm inflating a balloon and it's obstructing the flow of blood. So in this situation, this is not only not optimal for the patient, it's actually detrimental to the patient because it's increasing the SVR, increasing the demand that the heart has to pump against. Okay? And that's increasing it at the end of systole. Here we have a waveform where the balloon is inflating late. So we have our unassisted systolic beat, then we have our dicrotic notch where the balloon should have rapidly inflated. But because it didn't, we'll have this little W wave here, and then the balloon inflates. And you can see that we did not augment our diastolic pressure to 10 to 15 points higher than our systolic pressure. So although this did not hurt the patient, I didn't increase afterload, it was not optimal. So we can see it wasn't great, but it didn't hurt the patient in this situation. This situation is early deflation. So here at the beginning, we're calling this our assisted systolic. This is where the balloon rapidly inflates, so that was proper. The balloon remained inflated all the way here, but right about here, the balloon rapidly deflated early, and then the next systolic beat came. So although this was not detrimental to the patient, it did not reduce afterload. We can see that this and this is about the same, and our assisted is very close to our unassisted systolic. So although this didn't hurt the patient, it was not optimal for the patient. This here is late deflation. So here again, we had our unassisted systolic, our increase in perfusion, or our increase in diastolic pressure or augmented diastolic. The balloon, shoot, what the hell? Sorry, how do I get back? That's it? Okay, sir, do you know how I can fix this? Okay. So I can keep talking though. So in this situation where the balloon remained inflated for too long, that is detrimental to the patient. Now, in all of these situations, not for the inflation of the balloon, we can see the inflation of the balloon on timing the balloon at 1:1. Oh, perfect. Thank you. I can get to it now. Thanks. Okay. In all of these situations, I forgot what I was going to say here now. Never mind. Okay, but the end. Okay. So for inflation of the balloon, we can time that on 1:1 because we can see what a dicrotic notch is. We can see if we're creeping up under the dicrotic notch would be detrimental to the patient. We can see if we have a W wave, which would not be optimal, but it's not hurting the patient. But as far as looking at afterload reduction, we need something to compare it to. So in that situation, it has to be on 1:2. So at the change of shift or any change in rhythms, you should check that. You should at least for one strip across the page, have it on 1:2. You can freeze it, and Ed is going to show you how to do that. And then you can put it back to 1:1. So we're not interrupting the maximum help that the balloon is giving to the patient for too long of a period of time. Okay? So I think, Ed, the next slideshow? No, we're going to demonstrate the balloon pump now.
Hey, would you be kind enough to leave the waveform on?
Oh, sure.
Incorporate that in my chat.
The normal waveform?
Yeah, the normal waveform and whatever you have on.
Oh. Would you be able to put the other one back up?
Yeah, we'll get that. No. Good afternoon. My name is Ed Pavelko. I'm the clinical rep for the balloon pumps for Getinga. We were formerly known as Datascope at one time, so if there's any older nurses, you may have known them as Datascopes, if people call them that still. We're kind of glad to be back at Morningside. and all over. We have 90% of the world market. But you come back to using getting a balloon pump. So I'm not going to go into too much detail. Just kind of want to keep it simple, building on what you were talking about. Why are we using these? There is a change. You have the aero pump. It's a balloon pump. They both do the same thing. So there's a couple of subtle changes I'll touch on, but it's still not a huge learning curve when it comes to a balloon pump. I'll talk a little bit about timing and triggers. That's important, but the beauty of balloon pumping over the years is they really have become more automated in how they perform. And what you're going to notice on a balloon pump, and same with your other, for it to run, it needs a signal. We call it trigger. You will see a flashing green heart rate and a green heart. That means it's using the ECG to identify here comes systole. If it's not using ECG, lead 1, 2, or 3, it will automatically switch to the pressure upslope. And you'll see a little hash mark on it. It will be red. It's using the pressure signal as its trigger. A balloon pump will not run unless it has a trigger. So if there's no trigger, it goes on standby. It is safely deflated, but it's not helping the patient. It's not harming the patient. However, you never want the balloon to be on standby for greater than 30 continuous minutes, as blood may collect in the folds of that catheter. And on our machine, it will give you a blue banner how many minutes you've been in standby. So when you're working with a patient on a balloon pump, typically it's put in the cath lab. It's for those cardiogenic shock patients. We're trying to improve a little blood flow to the coronaries. It's not going to fix the problem. They still need to open it up, stent it, bypass if needed. But the number one complication you're going to be experiencing in the ICU is this distal blood flow obstruction. You have a catheter in there. So when you're taking care of one of these patients on a balloon pump, we'll talk about, well, what stops the machine? What do I have to be aware of? And be aware that it stops if there's no trigger. What causes no trigger? Maybe your leads fell off. It stops. It alarms you. There's always a help screen built in. There's an 800 number on the machine to call up to get a nurse 24/7, and it's pretty robust. Talk live. It does not have to be an emergency. So the other dreaded thing that might stop a balloon pump is a full arrest. The heart stops. The machine stops. It alarms at you. No trigger. You run in the room, and the patient's talking. Well, obviously, maybe just the leads fall off. But if it is a cardiac arrest event, treat the patient, not the pump. The pump knows enough to have stopped because it has no signal. It is alarming. The blood pressure is lower than it was. No augmentation, no trigger. If you need to defibrillate, if you need to do CPR, the pump will recognize the trigger event that you're creating, and it will at least be flexing the balloon, and it's not a standby for 30 minutes. So one thing stops a pump, no trigger. The other is the gas alarm. Now, you may dread the gas alarm. Balloon pumps give you a variety of gas alarms. The machine needs to shuttle 100 cc's back and forth through the helium extension tubing to that balloon, and it's going to do it very quickly. If there is any tortuous anatomy or a patient bends and kinks the leg, the pump senses that drag on the helium. Or if you have a disconnect, you get a rapid gas loss alarm. Deep breath, hit pause audio. What happens? It tells you the pump is stopped. There is a gas alarm. And it might be even some patients that are shivering coming out of the OR, the high P. Gas alarms do not mean there's a hole in the balloon. There is no gas getting into the patient. The balloons are fused shut at the tip. However, typically a gas alarm is explained as check your connections, make sure the patients have bent their legs, straighten things out, initiate a start. It will empty, purge, fill, and start running again. It will never overinflate the balloon. The balloon diameters are 17.4 for the 50 and 16 for the 30 and 40. Your aorta is significantly larger. However, in that event, you simply have to reattach, press start. It will never overinflate for the patient. However, when I'll talk a little bit more about a gas leak, when you need to be very concerned is if your balloon catheter, and I'm just going to move over here for a moment. By the way, it comes in a peel-away insertion tray, and if you're in the cath lab or it happens to be an ICU setting to put it in, I've already mentioned that there is a number on the balloon, and that tells you whether it's a 40 or 50 cc balloon. There's a chart how tall the patient needs to be. They can use R40 and a patient 6 feet tall, even though the box is 5 feet to 5'4". It's the lower number that you want to be concerned about. But you're going to use a 50 for a patient taller than 5 foot, you get a little more volume expansion, more blood pressure, and the 40 for a patient 5 feet and above. They come with an insertion tray. All of our balloon catheters will have one O2.5 guide wire, an 18-gauge needle, optional sheath. You do not need to use the sheath to put our balloon in. They are tightly wrapped to 7.5 French from tip to shaft. The 50 is 8 French. If you do want to use the sheath, it will have the appropriate sheath in the kit. So it's an 18-gauge needle, a tissue dilator stretching it up from 3 to a 7 French hole in the artery there, where you probably have access. And there's an optional sheath. I just want to mention the sheath. If they do use our sheath, it's wire reinforced, a little bit blunt on the end, and they will put the introducer in and twist lock it. That gives it a little taper, some support. This goes up over the wire, the introducer comes out. Blood is not flowing out anymore because there's a little O-ring in here. You may or may not use a sheath with the balloon. It's up to you. If there's severe scar tissue or obesity, you may want to use the balloon, but we don't have a mandatory requirement. In every insertion tray, there is one length of helium extension tubing. This is, one end will connect to the balloon, the other end, and on our pump, it's the pointy end, will simply fasten to the back of the balloon pump, right here. It studs in, we call it a slip-fit connection. It's made to come apart easily. If it does, you'll hit a rapid gas off, IUV disconnect, there's no harm to the patient. Reattach, start again. If you tangle up in blankets and things, you're trying to move, maybe EMS just arrived, if they just brought a patient in with a stretcher, you could easily put the pump on standby. It is always deflated at that moment, disconnect, reattach, press start. It will autofill and pick up where you left off. And the reason I mention that is our balloon pump will autofill on startup. You'll see it, I'll turn it on now, there's a green button over here. It will autofill on startup, which means it fills the appropriate volume. The machine knows what size balloon, whether it's a 30, 40, or 50, it has the correct volume. The aero pump has a little blue plug, orange plug, white plug. It has to know what the size of the balloon is. Ours understands it on a different system. But in any event, with the balloon, when you hit start, it will autofill and start pumping. Should you be balloon pumping a patient, and at any time you notice dry blood in this helium tubing, that is something to not ignore. The pump may be working just fine, but once every 2 hours, the pump stops, it says autofilling. It's like a syringe sucking back, and blood can get drawn into a small hole that perhaps was rubbed by plaque in the air or a hostile environment. It does it, it runs for 2 more hours, it does it again and again. And the blood eventually gets back into this tubing. It can make it into the machine, and the pump will do a shutdown that will say blood detect. But that's not the big deal. Who cares? The machine can be fixed. The big deal is if you ignore it, this clot in the balloon can be growing over time. Hour after hour, it does autofill. You can get a clot inside of the membrane of this balloon the size of a large monolith, like say a rock. And when they go to remove it, it's entrapped. And they have to actually do a cut down to take the balloon out. It's a rare event. So I minimize gas alarms, saying, hey, you get them all the time, and you do. But blood back in the helium tubing, with or without an alarm, is truly a leak, and it has to be addressed. And our recommendations: shut the pump off, clamp the tubing, have the physician come take it out sooner than later. But getting back to the other point, this is how the balloon comes packaged. Any cath lab staff here, the physicians are going to understand. They're going to hand this off to them. And there's very little prep involved. It comes with a 30 cc syringe and a one-way valve on it. And this one-way valve snugs onto the balloon before they even lift it out of the kit, and they pull negative on the balloon. That's it. We're just keeping it as tight as possible in its little plastic holder. But what you will absolutely hear is the physician do this, especially June and July. You'll hear this, they'll whistle. You're like, you cause no harm. But the balloon is now relaxed again. It's not as tight as it was. This simple little thing, if they don't do it, there's a chance the balloon's going to bunch up as they're trying to insert in the patient. So prep of a balloon is, they will pull negative on the valve, leave the one-way valve there. They don't need the syringe attached. There is a flush line, and On the side port of the Y connector, you'll have an A-line flush bag. Think of a balloon as nothing more than a long A-line. If you start at a radial A-line, you have a flush bag hanging with a transducer that's going to be 0 to atmosphere. Same thing. You have a flush bag hanging on the pole. The other end of that long transduced flush line will be attached. Once it's in the body, it will be attached here. The physicians will have a 3-way stopcock, will aspirate, manually flush it, and you should have a blood pressure tracing on the machine. Now, this is a very long A-line. And by the way, once they have needle access, guide wire, at that point, your slide will cover off. It feels slippery. It's got some tough line. Silicone. There is no latex on any of the product. But this is what the balloon will look like as it comes out, ready to be advanced up over the wire in small increments. Once it's at the proper position, and you had mentioned the distal and proximal markers, be sure which one you're looking at. They're not that bright, but they are there. Once it's in the proper position, if it's too high, left circulating obstruction. If it's too low, renal artery obstruction. Be aware that the aero balloon you have been using, they make a 50. I believe you have to be 6'2" to use it. Our 50 is fine at 5'4". So the balloon goes in over a wire, the wire comes out, your flush line is hanging on the pole, they connect, they aspirate, they give it a flush, we have a blood pressure tracing. At that point, the balloon is in position. The helium tubing that someone may have thrown off to you on our balloon pump will snug into the back. We call it the safety disc. There's an internal disc that fills with the proper volume of 100 cc's and shovels it back and forth. The balloon's in the patient's body. This will be snap-locked or sutured in place. The one-way valve comes off. Air cannot get into the balloon. We're not worried about that. This connects again. The aero balloon is kind of a clip here. Ours is a slip fit that can come apart easily by design. And I actually had a scenario once. I was taking a patient from the cath lab, Irish roto, on a vent, and the patient was stable, balloon pump, got to the elevator, the doors were closing, and did one of those, and the doors slammed shut. I'm like, great. I brought the patient up to the CCU, and I'm like, how am I going to explain this? But I used to work in the unit, and I figured they would expect such a thing. And the nurse saw this in about 2 seconds. Hey, are you kidding me? It's never pumped since on the next elevator. We connected it, it had not migrated. The reason I tell that story, I, as a nurse for many years until I actually read the manual, I had the death grip going down the hall. Oh my gosh, it's okay. But going back to the basics, so your balloon is in the patient's body. You may be using what's called fiber optic. And our fiber optic has, let me go back. You can have an airline flush bag hanging here. The balloon is going to go in over the body. The flush line is attached. Your transducers should be zeroed at the hydrostatic axis. Just like your radial line, probably exactly what you've been doing with aero. And on the pump, there is a button that says 0 right over here. You hold it for 2 seconds. Sometimes you have to read things. You get people pressing 1, 0. Well, traditionally, the A-lines have been notorious for long, clogging, dampening signals. The pump's having a hard time timing itself. So we developed, along with Aero, a fiber optic balloon, electronic cable. This orange cable, the cap comes off, it's a red little triangle, you see with the picture, it goes in here. And when you press start, our balloon is going to state that it is auto-filling and calibrating. It zeroes on startup. It zeroes anytime it auto-fills. So the balloon pump goes 0 on startup, and once every 2 hours the pump stops, empties, purges, and re-zeros. There's no reason for you to even press 0. It's meaningless with fiber optic. So you have a balloon with an A-line, which is perfectly meaning the beautiful tracing and fiber optic obtained. You have a transducer hooked up to this flush line that you're not using. Most hospitals will take that transduced signal and bring it directly to the bedside monitor like you would a radial airline. So you have 2 airlines, one going to the bedside monitor, one coming from the pump. And one of the very common questions we get is the balloon pump is reading systolic 100 over 50, but the bedside monitor is reading systolic 160 over 50. What's wrong? Well, your other monitors do not understand that that high is not systoling. That's a peak pressure during diastole. So one of the most important things we're talking about Proper timing, it has to be at the dichrotic notch. It needs to be down 100% before assisted. You can fine tune deflation. We don't lock you up. We're trying to get a better afterload reduction. But keep in mind, even if you don't have great augmentation, you still have an improved area under the curve. Your map goes up. When you put your pump on standby, you may have a mean arterial pressure of 60. Balloon pump's running, you may have a map of 90. So it's not just about afterload reduction, it's end-organ perfusion, altermentation, all the good things that go along with keeping a patient out of cardiogenic shock. And that is the number one reason the balloon pump is used, shock. Early on, probably the best outcomes, but again, sometimes it's used as a rescue device. About 140,000 of these are placed per year. And since the pandemic, and there's a lot more happening with balloon pumps going in for patients waiting transplant. So our utilization has actually gone up. It's not a disappearing therapy. Let me just show you the simple. I like to keep it simple. You're going to have, to hook up your balloon pump, you will have a long set of ECG leads, orange and lead sets orange. Green plug goes into the green plug. Your ECG is now on the screen. Pressure cable. If it's non-fiber optic, you'll notice that your biomed folks wire tight this red cable. That is your pressure line hooked up to the transducer. I have a simulator. I'm just going to connect that. And this blue guy, you don't have this, goes here. Now, if you do any kind of external monitors, you want to bring in a signal from a different monitor, that's called the external inputs ECG compression. I don't want to turn this into a 3-hour class, but I turn on the pump. I have a flashing diamond arc, meaning capturing the trigger, it will run. Now, keep in mind, the balloon pump in auto mode, and that's where you want to live. Auto mode simply means it's going to automatically select the signal. If my ECG's noisy, caught and shaking, leads fall off, it'll switch to pressure. Or maybe you're doing a case you can't get the leads on, it'll work off of pressure. It will switch back and forth on its own. It will automatically time itself. So in auto, I cannot change my trigger, I cannot change inflation. We never want to repeat the system. It will always looking for the dichrotic notch. It'd be at a 1-to-1 frequency. You could change frequency whenever you want. If you want to verify proper timing, you can do that. The 0 button will be here if it's not on fiber optic mode. If it's not plugged in, it will switch to the word 0, start standby. There's a button here called the augmentation. That's not your alarm. That is the volume going to the balloon. And at first start, it will jump to max. Max is normal. You never overinflate the balloon. But occasionally we have a position that there's something going on, compromising this patient. We don't want that kind of augment. Maybe it's 200. We don't want that kind of pressure. They can wean or decrease volume to the balloon if needed. But typically, you're at max, you're at a 1-to-1. Now, when you look at this control panel, it can be pretty complicated. First of all, the back of these, ECG pressure. And, oh, by the way, the balloon snugs into here. We give you a little printer back here. You can drop a paper in. You can set up your printer or if you want to catch a strip every 15 minutes, every hour type thing. Probably more importantly, we give you a Doppler. So on the front of your machine, number one complication, although rare, you can lose your leg with a balloon. So check pulses on a regular basis. Don't assume everything's fine just because your hemodynamics look good. Your patients can't communicate. Maybe they're intubated or sedated. Always be aware of just the blood. So your balloon pump. I have a flashing part. I connected the balloon. Oh, before I finish up. On the bottom, sort of your convenience keys. What are all these buttons? User preference. How bright? How loud do I want the alarms? How often do I want my printer to print? Reference line. I can put a ruler, a visual ruler on the screen. Initiate a fill. So if you're getting gas runs, read the help screen. It will ask you to initiate a fill. You could hit start. You'll probably be okay. It will empty fill. But when you hit fill, it does a deeper first cycle. Freeze display. Just freezes the action. There's an alarm in the lower right that is important. The AUG alarm. That is your blood pressure alarm. And when you start the pump, at 3 minutes of operation, it will look at whatever AUG is and set it 10 points under. From that point on, you change it on your own as you see fit. If you're in and out of AFib, balloon pump does kind of a neat thing. It says auto heart rate deflate if it's an ECG. What it means is the balloon decided, code. There's some long pauses for AFib. So it stays long, and if the beat comes in short, it gets out of the way. So it's not going to compete, but it's going to give you a little more support for the mean arterial pressure during AFib if you could be ECG trigger. If you can't, it's going to be a pressure trigger, and it's going to be conservative. It's going to try to drop. So keep your pump in auto whenever possible. Semi-auto. Well, now I have the option of using, maybe I want to use pressure. We're going to be doing chest BT on the patient, a lot of artifacted noise. And you know, if I go to semi-auto use pressure, it's just going to leave an A-line. It's not going to be distracted by what's happening with the ECG. You may have a patient that's paced. It will ignore pacer spikes unless you want to use them. That's, hey, here comes system. Pacer, lead/AV recognizes the V spike. It doesn't pace anymore. Internal. If you hit internal, we're trying to run at 80 beats a minute, but if there's a beating heart, it'll stop and say, ECG detected. You never want to compete with the heart. So that brings back an old story. What if the patient codes? I'm trying to use it. If the patient codes, treat the patient, forget the pump. It's an auto. It'll figure out what to do. Not much, it's going to flex at least. But if you had absolutely no signal, well then in the old days, we always had to teach nursing, go to internal, let it flex at 80 beats a minute, but turn the volume way down so you're not competing with your chest compression. Forget all of that nowadays, leave it in auto, treat the patient. So I'm going to hit start. We hooked up the patient, someone handed off the helium tubing, it does not matter who hooks up which end first, I'm going to press start. Your balloon pump will state what's happening right here. It's telling me that it's auto-filling, and because I'm using fiber optic, it's calibrated. It takes about 48 seconds. It will silently fill and be curved. It's going to flex 6 times. It's going to pause, and then your numbers are up, and it's up doing its thing. If it's a non-fiber optic, you can zero anytime you want, and when you hit start, it does 2 fill cycles and starts. So the pump right now, the physicians may be looking at you like, did you hit start? It stops. That's part of the pneumatic system measuring pressure, not only by light, but by volume and pressure around the aorta, around the balloon, and we're finally up and running. Now, what does the patient feel? Hopefully no pain. Relief. Maybe the ST elevations are coming down. They may be uncomfortable at the insertion site. They may feel a little fluttered. You shouldn't have anything that unusual. But this is what it's doing. And it's going to drop 2 beats. It's going to assess its timing. That's what it's doing here. My blood pressure, I am creating that high peak in the gray shade there during diastole of 112 on this screen. It might be 160. It all depends on stroke volume aortic compliance. So the pump's up and running. Life is good, you go on to do something with another patient. And then the patient decides to bend their leg, get restless, or maybe somebody disconnected. This is a high-level alarm. It's red. IAB was disconnected. It may have said check catheter, it may have said reconsider. The help screen, when I hit pause audio, help, it's color-coded in red. It says IAB disconnected. Reattach. Let's start. Now, if it was the case where I arrived in your ICU and I had no balloon pump, you'd probably be a little concerned. Hey, something. This should always be either sutured and stat locked. If there's a loop down here, there's a chance the balloon may have migrated because they can't. So your patient with a balloon pump, although they are very sick, they are not worse than the patient without. It's a very physician-driven device. They believe in the therapy, they may put it on early and regular. You may have other physicians that will only use it in a dire situation.
So, we're kind of running out of time.
Is that?
We're kind of out of time.
All right, one last thing I want to show you. And I'm going to be coming to your hospital and continue the show as needed, working with you. This pump is in what's called hybrid mode, and on screen it says hybrid up in the corner in blue. That means that I am hooked up, I am just plugged in, I'll have a gray symbol, I'm charging the batteries, they take 4 hours each to charge. If it's unplugged, you will have a green symbol of battery. Each battery lasts an hour and a half. You have 3 hours of battery runtime. It has a helium tank built in. That helium tank lasts 3 months, 24/7 pumping. It will give you 48 hours notice. If it's low, you can change it while it's running. We do not have a water trap to be concerned about. Our balloon gets rid of its condensation. And finally, if you had to get in a helicopter or an ambulance, this machine, there's a lever under here. Click it, and now it says, hey, I'm in rescue mode. That means I'm no longer attached to the helium tank. By the way, I'm no longer charging the batteries up because this will slide out. I'm going to make a mess of this. Thanks, you can hold the patient for me. This can slide out and travel in a suitcase and you're on your way. It will last 36 fill cycles for helium. Once every 2 hours, it does the fill cycle. We have optional AC adapters to plug it in and a separate helium tank to connect to the phone. And it weighs 50 pounds. So that's a big deal for air transport. When you put it back on, just remember, if you're showing your friends what I just did, you probably have to do this, but don't be shy about putting it back in the car. Make sure you hear the beeps. That means it's nested, it's back on the power if it's plugged in, and you have the big helium tank again. Sorry, I kind of crammed it in. I wanted to run over someone else's time. So,
That's okay. And remember, if you're going to do that, remember, it doesn't charge itself. So we're in the ambulance, you do have 3 hours, but sometimes we go out in the really cold weather, those batteries discharge faster than an hour and a half. Just pull another battery and stick it in the backpack with you, so if this does go dead, you don't know how long the battery's going to last, how long they're on. Just take an extra one with you.
and even if the pump's not turned on, and when you're going to steal it, you can always press the button and see what it is. We do make an AC power adapter that slides in the slot and you plug it in. And transport.
If you, quickly, if you get a patient in the hospital that's an arrow, that arrow plug will not fit into this. You, at that period of time, we are trying to order just the little end connectors, which are this piece here, just this piece. You'd have to steal it from another balloon, the way we're doing it right now. You know, you have to steal this from,
Yeah,
not from an arrow.
Well, if you're doing arrow to our machine,
Yes.
this segment
Yes.
will be in the arrow box. You won't break stability. You lift the cover up, take that out.
But a lot of times they don't bring it with
They
them.
don't have, yeah, so now you're in
They've
trouble.
already thrown it out when they put the balloon pump in.
And if you go in the other way, our balloon to the arrow pump, we give you a little adapter. Thank you.
Thank you.
If I knew that, I would dress up.
Sorry, so I'm going to just grab some pacemakers. For this, I think maybe people could move in a little bit closer. I have 4 pacer boxes to hand out to you guys. I think we're going to probably have to treat this more like a lecture than a hands-on, but I will give out the pacer boxes, and I'll do some drawing on here for you too. Okay.
This topic is very dear to me. I need to learn more about it.
If I forget, at the end, I do have some QR codes here, which will be some PowerPoints to a bunch of different lectures, including pacemakers, balloon pumps, hemodynamics, ABG interpretation, what else? Vasoactive medications, inotropes, so a bunch of stuff. So this is 2 different QR codes for Google Classrooms. Yeah, you take one. And actually, whoever wants to maybe spread them out, take a pacemaker. If you can. Okay. So I'm going to make an assumption that a lot of you have used external pacemakers in your practice. Regardless of what the brand that you use, the settings will all be the same. Okay, milliamps will be milliamps, millivolts will be millivolts. It's all the same, and they usually have very close to the same defaults on these pacemakers. The objective of today is to explain situations when temporary pacemakers are indicated, describe principles of pacemaking, illustrate normal and abnormal pacemaker behavior, and discuss steps that could be taken in troubleshooting temporary pacemakers. Indications for temporary pacemakers would be bradyarrhythmias, AV conduction blocks like second or third degree heart blocks, slow sinus or junctional rhythm. We can use it for suppression of ectopy. I think Michaela was talking earlier today about atrial pacing. Can be prophylactic for atrial fibrillation or prophylactic for PVCs. Permanent pacemaker malfunction, sick sinus syndrome, and it can also be used as a diagnostic tool, and I hope we have time to go over that towards the end, okay? But before we actually go into the pacemaker itself, you do have to be on the same page as me with the wording or the verbiage. The pacemaker itself is called a pulse generator. It just means that it sends out an electrical impulse at a certain time interval. If you have the rate set at 60, that means the time interval between beats will be exactly 1 second. The pacemaker is going to want to put out an electrical impulse every second. So when we're talking about rate of the pacemaker, the rate of the pacemaker is what controls the primary clock on the pacemaker. And the reason why I'm calling it a primary clock is because the pacemaker doesn't know what rate you have per minute. It knows the time interval in between each beat. Okay, so if I have it set at 60, it's 1 second. If I have it set at 75, it might be 0.75 seconds, or do you know what I mean? So it's just a time interval. So you're going to be hearing me say resetting the primary clock a lot during this lecture. Then we have the MA, which is the milliamps. It's a measurement of output that the pacemaker puts out. The higher the amperage that the pacemaker puts out, the more likely you are to achieve capture, meaning the more likely you are to have a response to your output. But on the other hand, the higher the output, the more damage over a long time you're doing to those temporary wires. I wouldn't plug my refrigerator in with a long extension cord that's like this, right? It would heat up and it would not work almost immediately. The pacer wires that we use are very thin. They can handle a certain amount of amperage, but not high amperage for a long period of time. Then we have capture. Capture is the response to the pacemaker's attempt to pace. So every time there's an atrial spike, it should proceed by a P wave. Every time there's a ventricular spike, it should be preceded by a QRS. If it's not, it's failing to capture, and amongst other things, one of them would be increase your milliamps or the power. The more power you give it does not make the patient's heart beat stronger. It either beats or it doesn't beat. Okay? We then have millivolts. For some reason, millivolts seems to be the part that a lot of people have trouble with pacemakers. That's how the pacemaker senses. So the heart itself puts out a certain amount of millivolts. If the pacemaker is sensitive enough, it will sense that. If it's not, it will fail to sense. We then have, and we'll go over that again in a second on the next slide, that we then have the AV interval. And we're going to call the AV interval our secondary clock. The AV interval is basically your PR interval, or somewhat the equivalent. It's the time period between atrial and ventricular activity, okay? The default on the pacemaker at an average rate is about 170 milliseconds. When we're talking about pacemakers, we almost always use milliseconds, not seconds, but 170 milliseconds would be 0.17 seconds, would be right in the middle of a normal PR interval, okay? We then have what's called PVARP. People don't pay too much attention to this, but I want to at least explain to you what it is. PVARP is post-ventricular atrial refractory period. It's a safety mechanism that the pacemaker has to prevent an RNT. So let me just draw this for a second for you guys. Hopefully you guys will be able to see it. So this is my rhythm, my P wave, my QRS, and my T wave. The PVARP every time the pacemaker senses ventricular activity, the PVARP, which is usually set at a default of 300 milliseconds, will ignore any atrial activity within this time frame. Because imagine if we didn't have a PVARP, and I was in a third-degree heart block, and I had a P wave right here. That P wave would be sensed. It would wait now 170 milliseconds and then fire right on the T wave. That would produce an R on T. So your safety mechanism to prevent an R on T would be your PVARP plus your AV interval. Because say I wait 300 milliseconds, and 300 milliseconds maybe is right here, then I have a P wave at 301. My pacemaker is still going to wait another 170 milliseconds before it fires. That means 300 plus 170. As long as my QT is less than 470 milliseconds, I will not have an RNT. Okay? That's why we have a PVARP. There are occasions when we will shorten the PVARP, but whenever we shorten the PVARP, we have to make sure we prolong the AV interval so that the two of them combined equals at least 470 milliseconds. We never want to be less safe than the default. Okay?
You said
470. Right. So if you look at the default on the pacemaker, for most average rates, the default on the pacemaker for the AV interval is 170 milliseconds. As you change the rate to very fast, it will become shorter. As you change the rate to very slow, it will become longer. But average, it's 470. We never want the two combined to be less than that, whatever changes we make. Okay?
Jumping ahead, but you can't go past it by default. I mean, if you know how to do it.
Yeah, and if towards the end, I will go over that with you guys, but I have to talk kind of quickly right now because we don't have all that much time. So now when we're talking about millivolts, millivolts is what the pacemaker uses for sensitivity. And sometimes I use decibels. Today I'm going to decide to use the fence again. The higher the millivolts, the higher the fence. So my pacemaker needs to be able to see over that fence in order to see the QRS or in order to see the P wave. If the millivolts is set too high, I can't see the other side of that fence. The higher the millivolts, the less sensitive the pacemaker is to stimuli coming into it. So I would lower that fence to say where the B is. And there I can sense my QRS, but I cannot see the T wave and I cannot see the P wave. So that sensitivity is set appropriately. So we're going to make an example and say A is set at 3 millivolts. B is set at 2 millivolts. That seems about right. If I go to 1 millivolt, which would be C, see that little T wave peeking out there? My pacemaker is going to see that and think it's a QRS. And it will not pace if it sees that, okay? There's a concept that you guys need to be aware of. If you forget this concept, when you're analyzing EKG strips, you'll get them wrong 50% of the time. The pacemaker does two things. It can pace or it can sense. It cannot do both. If it senses, it doesn't pace. If it paced, that means it did not sense, okay? So just imagine that my pacemaker paced when it was not supposed to. My pacemaker paced, but it wasn't supposed to pace. What was it supposed to do? Sense. It failed to sense. If my pacemaker did not pace, I had a long pause and the pacemaker did not pace, it didn't pace, but it should have paced. What made it not pace? It sensed. It oversensed. If you can remember that, you can make a diagnosis of these EKG strips, whether they're permanent pacemakers, whether they're transcutaneous pacemakers, whether they're transvenous pacemakers, they all look the same. Okay, so this is just a reminder again about the flow. So milliamps is the output of the pacemaker. Millivolts is the input of the pacemaker coming from the patient to the pacemaker. It's what it uses for sensing. 3 different types of pacing. Transcutaneous, which is the simplest to use. It's really truly used only in an emergency situation. It's the pads on the front and back of the patient. That will only allow you to ventricularly pace. So with that type of pacing, you're guaranteed you lose your atrial kick. Now, depending on the heart function of the patient, A patient may do fine with just ventricularly pacing. But if a patient has a form of diastolic dysfunction and they need filling, if they lose that atrial kick, sinus rhythm at 35 may be better than ventricularly pacing at 80. You have to see what's best for your patient at that moment in time. But this is truly for an emergency situation. It is going to hurt the patient. No doubt about it. You have to say to the patient, tough. Without it, you don't survive. You can sedate the patient. You can give the patient pain medication. You may even have to intubate the patient if it's too much. We've run into a situation where I've walked into a unit and I just saw ventricular spikes across the screen with an idioventricular rhythm underneath. And when I asked the nurse, what's going on with that pacemaker? Oh, well, the patient was complaining so much that it hurt, so I turned down the MA and I figured it was better than nothing. It wasn't, it was worse than nothing. Because now the monitor said you were at a rate of 80 because it thought all those spikes were QRSs, and in the background, there was the patient's real heart rate. And when we looked in the morning, the creatinine went from a normal of like 0.8 to like 2.1 by the morning. We put a transvenous wire in, and within a couple of days, it came back after a permanent pacemaker. But a transvenous pacemaker is also an emergency situation pacemaking, but it can be left in for a longer period of time or used for a longer period of time. It does not hurt the patient. But again, the best you're going to get is ventricularly paced. And if your units don't have this together somewhere, because remember, this is for an emergency, it's going to be a 6 French introducer. Try to get the ones that have the sheath built into it, because the sheaths a lot of times are a different brand than the introducer, and they don't fit together. And then your pacer wire. This is really all you need. Okay? They do make transvenous wires that also can atrially pace. Our hospital does not have one, and most places don't use them in an emergency situation. But then why would I use it? It's meant for an emergency situation. Okay? Then we have the epicardial pacers, which is mostly what I'm going to talk about today. For those situations, you would have had to have had open heart surgery. The epicardial wires, if they're bipolar, you'll have 2 wires coming out of the right side of the chest. Those will be your atrial wires. You'll have 2 wires coming out of the left side of the chest. Those will be your ventricular wires. They're never switched. They're supposed to be color-coded, but they rarely are. They will be 2 blue, 2 white, or the white will be on the ventricular. They'll be switched up. Just go by where they're coming out of the chest. In fact, sometimes they'll come out of the operating room, occasionally switched. You have to check it. Now, you would end up being VA paced, basically just V paced, if you try to AV pace the patient. But if you tried to just V pace the patient, you would be A pacing the patient. There are 2 types of wires. Almost every institution right now uses bipolar wires. 2 wires coming out of the right and 2 wires coming out of the left. On occasion, they'll come out with 1 wire, either out of the right or the left or both. In that situation, you cannot use those wires unless you ground them, which means that you're going to have 1 wire going into the black terminal. Unlike everything else in the world, red is the ground in this situation. Yes. Black is the power terminal. There's some weird thing about they're grounding the patient, not the pacemaker. But just remember that this is the power one. This is your ground. A quick way to ground is to take a 23 gauge needle, pull the cap off it a little bit, bend it slightly, and pierce through the skin and out the other side. Like you're giving a sub-Q injection that went out the other side. And then you can stick it into the red terminal and use that as a ground, and then the pacemaker will work. If that worked in an emergency situation, you can then get a PA or a doctor or someone, a nurse practitioner, to suture another pacer wire to the skin. But remember that pacer wire can only be used as a ground at that point in time. And that's just what the pacemaker looks like. You guys, whoever has pacemakers, you can turn them on. Okay, so different modes of pacing. Does anybody have them? Yeah, okay. Does everybody know how to turn them on? You just got to hit the power button, okay? There are different modes of pacing. The first type is atrially pacing. Now, in order to be able to atrially pace your patient, you have to have a competent AV node. If you're in a third, a second-degree heart block, you cannot just atrially pace this patient, okay? The next type of pacing would just be ventricularly pacing. Remember, ventricularly pacing is fine, but you are going to lose your atrial kick. It is a very good backup for emergencies if you're not actively pacing the patient at this moment in time. Once you start actively pacing the patient, if you ever have the ability to A-pace or AV pace, that's the better choice than just V pacing. Then we have AV pacing. Again, you don't have to have a competent AV node for that, and it will be hemodynamically as good as sinus rhythm at that same rate. Okay? Okay, there's a coding system for the pacemakers. The first letter in the coding system can be a V, an A, or a D, meaning both. That is what the pacemaker has the ability to pace. The second letter can be a V, an A, or a D. D means both, atrium and ventricular. That is what the pacemaker has the ability to sense. The third letter can be an I or a D. A D would include a T, which means triggers. It's triggering the secondary clock. Remember we mentioned that before? The AV interval is your secondary clock. Every time I either sense or pace the atrium, it triggers the secondary clock to count down 170 milliseconds. Within that time frame, if there is no QRS, it will ventricularly pace. If there is a QRS, it will reset the primary clock to count down 1 second from that point on again. Okay? So triggers just means some of the pacemakers, like the ones you have in your hand, will call it tracking the atrium. I prefer the word trigger because it's triggering the secondary clock because it has the ability to track the atrium. But it's still a T, either way. Okay, so we have AAI, which is an okay type of pacing, but remember, it's not a good emergency backup. Because if I go into a complete heart block, I'll just have atrial spikes across the screen. But the way AAI would work is you're going to have a P wave, which it senses. It resets the primary clock. It then waits 170 milliseconds. I'm sorry. It then waits 1 second. Within that 1 second, if there is no P wave, it will pace atrially. That will reset the primary clock. It then waits 1 second again. Within that 1 second, if there is a P wave or there is atrial activity, it will sense it, inhibiting the pacemaker from firing by resetting the primary clock to count down 1 second from that point on. So AAI is a fairly simple type of pacing, but remember, you have to have a competent AV node. If you have a risk of the patient going into another rhythm, it's not a good backup setting. Okay? VVI is a fairly good backup setting for post-cardiac surgery patients that are not being actively paced at this moment in time. What it does, it'll sense the QRS, sense ventricular activity. It will set off the primary clock to count down 1 second. Within that 1 second, if there is no QRS, it ventricularly fires, resetting the primary clock. If within 1 second there is a QRS, that QRS inhibits the pacemaker from firing by resetting the primary clock, and it will continue to go on like that. It's fairly simple, that's all it does. DDD is the more complicated one. I think I might want to just draw this. So on DDD, that pacemaker has the ability to pace the atrium and the ventricle, sense the atrium and the ventricle, and inhibit as well as trigger. Okay? So, with a DDD pacemaker, if this pacemaker goes a period of time and it does not sense anything, I'm going to use 60 again. Not that we use 60 a lot, it's just for me the math is easy. It's 1 second. Okay, so the pacemaker is waiting. There is no QRS within 1 second. What does it do? It atrially paces. Hopefully there's a P wave. That atrially pacing will set off the secondary clock to count down 170 milliseconds. Again, that can be changed. That's the default on the pacemaker. After 170 milliseconds, if there is no QRS, it will ventricularly pace. Hopefully there's a QRS. That will reset the primary clock to start counting down 1 second from that point on again, and so on. If there's no QRS, it will atrially pace. 170 milliseconds. If there is a QRS, it will sense it, resetting the primary clock, inhibiting itself from pacing by resetting the primary clock. Okay? If now, so you can see that the way I set it up so far is this pacemaker on DDD can A pace at 60 and it can AV pace at 60. There's something else that it can also do, and this confuses a lot of people because even like intensivists that I've worked with will say, I just got report that the pacemaker is set at 60, why are we pacing at 85? It's because it's tracking the atrium and triggering the secondary clock. So every time there's a P wave that's faster than the low rate, that triggers the secondary clock to start counting down 170 milliseconds. Within that 170 milliseconds, if there's no QRS, it ventricularly paces. So you see how this pacemaker on DDD mode can A pace at the low rate, AV pace at the low rate, or ventricularly pace at any rate between the low rate and the high rate that's set on the pacemaker. Some pacemakers, depending on the brand or how they set up, have a high rate set at 110. Some of them will be set up to always be 30 higher than the low rate. I prefer it to be 110 because I might want my pacemaker to be set on 50, but I might want to pace ventricularly if my P waves are going across the screen at 90. I don't want to be limited to that. But because what will happen is if you reach the high rate, the pacemaker will start going fast and then slow, and then fast and then slow. It gets confused. It starts wandering. Okay? Okay. The backup that we use at Mount Sinai Morningside does not have to be the backup that you use. You can use DDD as a backup, but it's much harder to get it to work right. If you're setting a pacemaker up on DDD mode and you want it to just be a backup, you are more likely than not going to have to shorten your PVARP and prolong your AV interval out to 300. Or else you're going to just continue to start V-pacing because every time it senses the atrium, it's going to trigger that secondary clock. It's only going to wait 170 milliseconds. What if I'm in a slight first-degree heart block, which is very common post-operatively? It's going to continue to just start V-pacing. So we came up with, we're going to use it on VVI of 50. Why did we choose 50? Does anybody know? Why not 60? I'm going to say that the majority of you probably use 60 as a backup, right? The reason why we don't use 60 is because your alarm is set at 60. What will happen is your patient will Brady down, you'll start to ventricularly pace at 60, and your alarm will never go off. Remember, that 60 was a backup in case of an emergency. It's not meant to be left like that for a long period of time. If you start to ventricularly pace, you should immediately go into the room, see what the underlying rhythm is, and set your pacemaker up to make the patient as hemodynamically stable as possible. VVI is not as hemodynamically good as possible, okay? So if our patient Brady's down, the alarm will go off, and it will start pace ventricularly at 50, we will immediately go into the room and change the settings, okay? We also set our MA at 25. But 25 will ruin the wire very quickly, right? Problem is we're not actively pacing the patient. So it's not hurting the wire at all. And in an emergent situation where the patient Brady's down, I want to have the best chance of capture possible. I'm not going to hurt the wire for even a few hours pacing with an MA at 25. It's when you start doing it for days. Now, but you could say, well, I checked the sensitivity and I started to capture at 7. So I will double that as a safety threshold and make it 14. The problem with that is that the same thing that could have all of a sudden make a patient become bradycardic, which would be maybe acidosis, hypoxia, hyperkalemia, those are the same things that would cause the pacemaker to have failure to capture. So that's why if we're using it for an emergency backup, these would be our settings. And those settings don't get changed unless you are going to actively pace the patient. We do have a lot of times that the doctors or some of the nurses always turn it down to 10 because that's the default. But if you're not actively pacing, and they'll say, oh, but we're going to ruin the wires. But you're not because you're not actively pacing the patient. Okay? But again, you have to follow the protocol for your unit. If that's your protocol, you have to leave it unless you take the initiative to change the protocol. Okay, as far as testing for stimulation, so say you are now going to start atrially pacing. Or, I'm sorry, you are going to start pacing this pacemaker, patient. You're going to have to check a threshold because now you're actively pacing the patient. In order to check a threshold, you have to be pacing the patient at least 10 higher than what your underlying rhythm is. At that point in time, when you're pacing, if you're pacing the atrium, you will turn the MA down, 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 down the pacemaker until you lose your P wave. Then you will go up, 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 up again until you regain your P wave. That is your threshold. Say that threshold was 5. You are now going to double that. That's going to be your safety threshold. You're going to put it at 10, and that's what you leave it at. You do the same thing with the ventricle. Okay? You go down, 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 down on your MA until you lose capture. You go back up, 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 up until you regain capture. Whatever that number says, you double it. Now, sometimes you can't double it because what if it starts capturing at 15? You can't put it to 30 because the ventricular output on the pacemaker only goes to 25. The atrial on the pacemaker only goes to 20. So in that situation, you would have to leave it at the max. There's also threshold testing for sensitivity. For the most part, my recommendation would be to leave the sensitivity, the millivolts, the way it is, unless it's not working properly. Okay? The default for the ventricle is 2 millivolts. The default for the atrium is 0.5 millivolts. And that's for most brands of pacemakers. Okay? It might be 0.4, it might be 0.6 for the atrium, but it's very close to that. But if you are going to check it, you would have to first decrease the milliamps on your atrium and the ventricle, depending on which one you're testing. Because when you're checking sensitivity threshold, you are going to inappropriately be pacing for some period of time. You could create an RNT. Okay? So, but if I put my milliamps all the way down to 0.1, I could still see on the pacemaker by the blue and the green dots whether I'm sensing or attempting to pace. But that amount of milliamps won't even make it down the wire to reach the patient, so you can't cause any harm to the patient. So in this situation, you would put the sensitivity initially at the max, which could be 0.8 for the ventricle or 0.4 for the, 0.8 for the ventricle, 0.4 for the atrium. Depending on which one you're testing, you're going to increase that number, meaning decrease the sensitivity, until it starts pacing when it's not supposed to. Now you're going to start increasing the sensitivity by lowering the number until it starts to sense appropriately. Whatever that number is, you double the sensitivity by cutting the number in half. Okay? Now, the thing is, if you are failing to sense on the 0.2, what do? You just turn the dial as far as it will go to the most sensitive, because the default is 2 millivolts. If you click the dial 1 click to make it 1 click more sensitive, it's 1.5. If it starts working at that level, that's my sensitivity threshold. I need to double the sensitivity. I need to put it to 0.75. It only goes to 0.8. So if it's not working on 2, just turn the dial to the right as far as it goes. That increases the sensitivity. It brings the number down, and that's the best you're going to get. For the atrium, the default is 0.5. The most sensitive is 0.4. So if it's not working appropriately, if you're failing to sense at 0.5, you go to 0.4. If it's not working, you have to troubleshoot a little bit more. Okay? I'm going to skip that slide. We spoke about post-ventricular refractory period before. Remember, that's your safety threshold to not have an RNT. It's your PVARP plus your AV interval. That's your safety threshold. When you're analyzing your strip on a patient that is being paced, if you can, try to see what the underlying rhythm is first, meaning turn your pacemaker rate down, down, down until you can see the underlying rhythm. As long as they're hemodynamically stable enough to stay like that for 5 or 10 seconds, okay? Then you're going to go back up. Once you're actively pacing the patient, every spike should have something preceding it, either a P wave or a QRS, okay? There's only 3 problems that can occur with a pacemaker once the pacemaker is set up appropriately. There could be failure to capture. Failure to capture, what do? If I'm just talking about the pacemaker right now, I increase the milliamps until it captures, and then I double it. I can have failure to sense or undersensing. That means that there are pacer spikes where I don't want them. It means the pacemaker paced when it shouldn't have. Now, people will call that a lot of different things. What I prefer you guys do is always convert it back to failure to sense. So if the doctor says, oh my God, the pacemaker's competing, the pacemaker's competing because it's failing to sense. The reason why I want you to say failing to sense, because how do I fix failing to sense? I increase sensitivity. How do I fix competition? It's not as easy to think about that in your head. So if I'm failing to sense, I increase sensitivity. The other thing that could happen, it could be called is pacing inappropriately. That also means failure to sense or undersensing. So always try to convert it back to one of these three things. It makes it easier to fix. The other thing would be oversensing. I'm oversensing, which means I'm not pacing. I want the pacemaker to be pacing because I'm bradycardic, but it's not pacing. It's not pacing, so what is it doing? It's sensing. It's oversensing. How do I fix it? Decrease the sensitivity, bring the number up until I start pacing appropriately. Okay, we're getting to strips. Okay, what kind of pacing is this? Somebody just yell it out. Atrially. Am I atrially capturing? How do I know? The spike doesn't mean I'm capturing. The spike means the pacemaker attempted to pace. I know for here, there's two reasons why I know. Okay, perfect. First is, I have a QRS. I conducted through. There's no chance that we just set it up like this. You look to see first, is there a P wave? But even in this situation, if there's no P wave that I can see, there is a P wave because I had the ability to patient conducted through. What kind of pacing is that? Ventricularly pacing. The reason why I know it's ventricularly pacing because it's right next to the QRS. And I can see that it's a ventricular beat. In order for something to have originated in the ventricle, the QRS has to be widened and the T wave has to be in reverse morphology from the QRS. Okay? What kind of pacing? AV pacing. Am I ventricularly capturing? Yes. Am I atrially capturing? How do I know? Because what? Well, I see a spike, but I also see a P wave. In this situation, if I don't see a P wave, I'm not sure if I'm atrially capturing because I'm also ventricularly pacing. So I don't have to have a conduction system, an AV node conduction system that works here. So I have to see a P wave. If I don't see a P wave, what I would do is I would turn my MA all the way up. I would check my connections. I would then see if I see a P wave. If I don't see a P wave, I'm going to go through all of my leads. If a P wave exists in one lead, the P wave exists. If I still don't see a P wave, the only other way to test it, and you might want to get the intensivist at the bedside for this or not, you're going to either turn the MA all the way down on the atrium and turn it off, or pull the lead like this. You're going to be looking at your arterial line. If when I pull this lead out, my pressure dropped slightly, doesn't have to be much, and then I put it back in, oh, my pressure just went up. I lost and then I regained my atrial kick. No matter what type of heart function this patient has, there will be somewhat of a loss when you lose your atrial kick. If they have diastolic failure, when you pull this out, the pressure is going to drop like a rock. If they have systolic failure, they don't really need that much filling. They are already overloaded. That losing their atrial kick doesn't hurt them as much as a patient with diastolic, but it will still drop. Okay? Now what you're going to do is now you can check your threshold. Your pressure is up again. You're going to turn your atrial output all the way up. You're going to slowly go down, 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 down. Oh, my pressure just dropped. Let me go back up, 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 up. Oh, my pressure just went up. That's my threshold. I'm going to take that number, whatever it is, and double it. Okay. What kind of pacing? It's V pacing. How do I know this mode is DDD? Because there's no way I was good enough to time it with the P wave like that. The pacemaker had to do that. So this pacemaker has the ability to sense the atrium, triggers the secondary clock to count down 170 milliseconds, and since there was no QRS within that 170 milliseconds, it fired on the ventricle and it captured. Okay, so the only type of pacemaker that can do this would be a DDD mode. Okay, what type of pacing? Atrial alone? AV pacing. So I can see that I have a QRS, but do I have a P wave? I don't. So you're going to go through all those steps again. You're going to check your connections. You're going to increase your MA all the way. If the P wave exists then, okay, creep down on your MA until you lose it, go back up until you regain it. That's your sensitivity threshold, you double it. If that's not the case, you're going to have to go through all of those other steps of pulling the lead. If you don't have an arterial line, there's no way of checking other than seeing a P wave. Because you can't take a blood pressure and then pull the lead and take another blood pressure. The pressures could still be very close, but you could have been capturing. All right, now we're running into problems with the pacemaker. So it looks like here we have a P wave, which triggered the secondary clock to count down 170 milliseconds. We then attempted to ventricularly pace. It looks like I captured, but if we look further, it was probably coincidence, because that's the rhythm. The next one looks like I sensed the atrium, waited 107, triggered the secondary clock, attempted to pace the ventricle. What happened? Failure to capture. How do I fix it? What do I increase? Increase the milliamps. Increase the output on the pacemaker. How much do I increase it? Until it captures, and then double it. Perfect. Okay. So the three most common causes of failure to capture, I went over those earlier, would be acidosis, hypoxia, hyperkalemia. Okay? The solutions for failure to capture would be check your connections. Now remember, whenever you have ventricular or atrial wires, epicardial wires, you should be checking them at the beginning of every shift. Meaning, you should make sure that these connections, the atrial ones are taped to the right side of the chest, the ventricular ones are taped to the left side of the chest, so there's no confusion. You can have a gauze under them, but there's no reason to wrap this in gauze that you can't see the pins coming out of here. Okay? It makes sense to have a gauze under it so that the patient can't dig into it. But a piece of silk tape over it like this, you can still see through it enough that you can see that the pins are in. Right? You don't want to look silly that you call the intensivist over to the bedside and you're like, my pacemaker's not capturing, I don't know what to do. And they come to the bedside, they pull the tape off and one wire's out like this. Right? You want to be able to fix that on your own. If you've gone through everything, you've increased your MA to the max, you've checked your connections and the connections are good, and you're still failing to capture, you could potentially try doing this. Taking both of them out, switching them. It's called reversing polarity. One wire might not be able to carry enough current through it, but it may be able to be good enough to use as a ground. So switch polarity. If that doesn't work, you can change these wires into a unipolar wire, which means you're going to take both of them out, the red one out, and you're going to put both of them into the black terminal. What that does is that it doubles the thickness of the wire, decreasing the resistance through that wire in half. And then you have to take a needle through the skin and stick this on the pointy end of the needle without sticking yourself. I don't know if anybody in the room here, would feel comfortable doing it by themselves. But if you have the intensivist or a PA or a nurse practitioner at the bedside with you, I think the two of you can do it together, but you might need to remind them, maybe we need to do this, right? Because most people have learned these tricks, but they kind of forget that they can do it. Now, I'm not going to say do it just because I feel like pacing the patient, but if the patient truly needs it for hemodynamics, you're going to try everything that you can to get this pacemaker to work properly. Okay, what kind of pacing? Did we see this one already? No, okay. So it looks like I had a P wave. I'm going to tell you that this is a DDD pacemaker. So you see that first P wave here? The pacemaker should have sensed that. And then it should have waited 170 milliseconds and paced the ventricle. It didn't. It did not see that. So what did it do? It atrially paced. That set off the secondary clock to count down 170 milliseconds. So right off the bat here, what are we calling this? Failure to sense the atrium. How do I fix it? Increase my sensitivity on the atrium. Which way do I turn the dial? To the right. The number will go down. So whenever I want to increase something, I always turn it to the right. The number will take care of itself. So even if you don't remember that, oh, the lower number is more sensitive, remember that if I want to increase the sensitivity, turn the dial on the pacemaker to the right. Okay? Okay, what about this one? These are pacer spikes here. Should those pacer spikes be there? All right, they should not be there. So it looks like I atrially paced. It looks like it conducted through and there was a QRS. Right in the middle of the QRS, it tried to ventricularly pace that patient. That wasn't needed. So what happened here? It failed to sense or undersense the ventricle. How do I fix it? Increase the sensitivity. Which way do I turn the dial? How far do I turn it? All the way, because the default is 2 and the most sensitive is 0.8. There's only be 2 clicks in between there, so you just turn it all the way. Whenever you have failure to sense, whether it's the atrium, you just turn the dial to the right all the way. If it's the ventricle, you turn the dial to the right all the way. If you've already done that, you're going to have to troubleshoot some more, make sure the connections are attached correctly. In this situation, you can also reverse polarity. It may work better with the wires the other direction. If you do that, potentially you could lose capture now, but maybe it will work. You can trial it. Okay, we kind of went through all these causes. All right, well, this is a VVI pacemaker, and we missed a lot here, and it caused a lot of harm to this patient. So it looks like this was a ventricular spike here. What was the problem? Failure to capture. So how would I have fixed that? Increase the MA. Here, it looks like there's another spike here. Should it have fired here? No, what should it have done? Sensed, so it failed to sense. How would I fix that? Okay, so it went on and on. It went over for a period of time. Eventually, I had an RNT. Put me into VFib. How would I fix that? Compressions and shock the patient. Turn the pacemaker off for right now. Okay, what about this one? This is another VVI pacemaker. So it paced here, it paced here, it paced here. Should it have paced here? It should have ventricularly paced there, right? It's not supposed to see the P waves. But in this situation, it did sense the P waves, and the pacemaker thought they were QRSs, so it didn't fire. So this is over-sensing the atrium. I'm sorry, over-sensing the ventricle. It sensed the P waves thinking they were QRSs. So how do I fix that? Decrease sensitivity. Which way do I turn the dial? To the left. Okay. Okay, this slide says competing, but let's look at the rhythm itself. It looks like I ventricularly paced and I captured. Here it looks like I ventricularly paced and failed to capture. That is not a ventricular beat after, it's a normal beat that just happened to be there. The next one is I attempted to pace, and I was right in the middle of the QRS. The next one, it paced right after the QRS. So there's actually 2 problems occurring here. What are they? One is failure to capture. The other one is failure to sense. Okay? This is just something that you shouldn't do. Somebody here was checking the rhythm by turning the pacemaker off or pulling the wires. So the patient lost their rhythm completely. There is a risk here that if you do this for too long of a period of time, very quickly the patient can become acidotic, you turn the pacemaker back on, and the pacemaker will not capture. So you don't want to do this for any length of time. The better way to do it is to decrease the rate slowly. If you reach 30, which is the lowest rate that you can turn the pacemaker down, and the rate is slower than 30, you're just going to document that the rate is less than 30, but beyond that you don't know. Okay? That's just a whole bunch of different things that can change thresholds for the pacemaker, okay? Okay, so these are practice strips. What kind of pacing is this? Atrial, good. What kind of pacing is this, and what's the problem? It's AV. There's a problem here, though. Failure to sense the ventricle. Good. How do I fix it? Increase sensitivity. See how it's easy when there's only 3 problems? You just have to identify it. If you call it the right thing, the fix is kind of easy. What kind of pacing? V-paced, okay. This is a problem. What's the problem? Failure to capture the ventricle. Actually, if I look here, it's probably failure to capture the atrium also. So I need to turn the MA up, but check all of my connections also. What kind of pacing? Good. What mode? On this one. What mode? DDD. How do I know it's DDD? Right, because I'm tracking the atrium. I know that because I triggered the secondary clock to count down the 170 milliseconds, and then I pace the ventricle. It's very consistent with the atrial activity. This is a DDD pacemaker, not a DVI pacemaker, DDD. So this pacemaker should have the ability to sense both the atrium and the ventricle. Did it sense the atrium? No. So it failed to sense the atrium. How do I fix it? Which way do I turn the dial? To the right. How far? All the way. What about this one? This is a VVI pacemaker. Oversensing. How do I fix it? Turn the sensitivity down. Which way do I turn the dial? To the left. What will the number do? It will go up. Good. Okay, an atrial EKG. This is how we can use this as a diagnostic tool. I can first say that I'm having trouble seeing my P wave. I'm not really sure. Is this patient in atrial fibrillation? Is this patient in a third-degree heart block? Is there a P wave? I can turn my milliamps on my pacemaker to 0.1 so that even if it fires, it's not going to hurt anything. Okay? Then I'm going to prolong my AV interval as far as I want you guys to go, which would be 270, which is the max that you can go without adjusting the PVARP. Okay? So you're actually making it safer by increasing your safety threshold against an RNT because you're going to go from 470 to now 570. Okay? And then you will see, hopefully if you're in sinus, you'll see these dots on this pacemaker going blue, 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 blue. We done? Okay. Blue, 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 blue. Okay? That would mean you're in sinus. If I saw blue, 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 that would be a second-degree AV block, and so on. But I can't take this and put it in the chart. So what I want to do is I want to do an atrial EKG. So there's a couple ways to do it. You're going to take the atrial wires, disconnect them from the ports. You're going to take one to the white lead and one to the black lead. You can take both to the white lead. It works also. Sometimes it's better. But initially try like this, and you're going to run a strip in lead 2. That will give you a big spike for your P wave. If you look up there, you can see the big spike is your P wave and then the QRS. In this situation, you can see it marching through. So this would indicate that I'm in a third-degree heart block here. Okay? So it just makes your P wave larger. I think we're done. All right? Thanks.